everyone, and thanks for coming and this sort of crazy day, isn't it? Lockdowns and all sorts of things. We're presenting today from the Department of Oncology at Monash Health, School of Clinical Sciences, Monash Uni. So we are located on the Clayton campus, and we do cancer research, and in particular clinical trials and translational research, which means samples on biospecimens, samples from trials. We also have a very strong qualitative research. So you will hear tonight from three of my PhD students, all of whom are also my colleagues. They are medical oncologists. So to be a clinician scientist means you cross both worlds, and we often hear the term bench to bedside, but really what I think is most important is bedside to bench, or at least as a half of the loop. So you'll hear a range of topics tonight, and we do have other students, but we just have the best. No, we've got three fantastic students, but we do have other projects, so quite a diverse range of projects in our department. If you're and we have, purely lab-based projects, all the way through to purely clinical projects. But you'll hear from three of our PhD students tonight, and we'll make this pretty informal. We've got half an hour, so I won't delay, and we can have questions. Probably we'll do a couple of questions specific to the presentations after each one, and then some more general presentations. So I might start with, shall we do it in the order that we agreed? I'm just conscious Amy hasn't got home yet. Can we let Amy go first so she can possibly be on her way as well? Okay. So Amy can tell you that the life of a PhD student and a cancer doctor involves working pretty hard. She worked pretty hard today, but it's also to see the reward of your labours. So take it away, Amy.
Hi, everybody. I'll just share my screen. Thanks, Eva, for the introduction. I have elaborated slightly on that in my slides, just because I think as a student, I guess I didn't have a great idea of everything that would come after being a student. And I just think it's interesting to have a look at where people's careers take them and the pathways you can follow. So as Eva mentioned, I'm a medical oncologist at Monash Health, but also a brand new PhD student as of July, so for about the last month. I just thought I'd quickly tell you about my background. So my undergraduate degree was medicine, but I also did an honours year during that as a research year, and that was in infectious diseases, which at the time was what I was thinking I would go into, and it was about hepatitis B response in patients with HIV, which might have been a little bit prescient of where this project has taken me, and I'll tell you about my new project in a minute. And then my postgraduate training was in medical oncology through the College of Physicians.
Something's hard to drive.
And I did just want to, I guess, reassure everybody that
we're
all beginners at the start of this, and I'm definitely still a beginner at statistics, at database design, and at interpreting lab data and more lab-focused papers. But the things that I've gained from having worked for several years are the clinical context of the research. So I think whichever way you come at it, you could learn things from your job, or you learn things by doing more study, and it all kind of comes together in the end. So with no further ado, I will jump into talking about my project. So we are doing a research project into COVID-19 vaccine responses in patients with cancer. And I'll just show you a little bit of the rationale about that before I tell you about the project. So From early last year, we found that COVID-19 infection in cancer patients had worse outcomes than in other patients. So looking at patients who had COVID-19 and cancer, they had highest hospitalization rates compared to patients who had COVID-19 and no cancer, or patients who had cancer and no COVID-19. And similarly for death rates on the other side of the slide. This is in the US, and they also found a disparity between African American patients versus patients from a white background. Similarly, in China, they compared patients who had no cancer at all, or patients with early stage cancer, so that had not spread elsewhere in the body, to patients with metastatic cancer, and found that the patients, particularly with metastatic cancer, had much worse outcomes from COVID-19. And so the question as to why that result is so poor is really a very complex one. And when you actually split up by different types of cancer here, you can see that this is the proportion of people who had severe events from COVID-19. It's actually different depending on the type of cancer you have. And this probably relates partially to the type of cancer and partially to the type of cancer treatment that you receive. And again, in this slide, certain types of cancer made people do worse, certain characteristics of patients with cancer, being older, which we know many cancer patients are, and certain treatment side effects, for example, neutropenia, which can happen after chemotherapy, contributed. So the rationale for studying COVID-19 vaccine response in patients with cancer is that we know they do worse, but with COVID-19, but we also know that not every cancer patient is the same. And so we want to know, one, how can we best protect our patients from COVID-19, but also how do these different factors that affect infection outcome affect vaccine response as well. And I just wanted to show you very briefly, in patients having a COVID-19 vaccine, we do have some data from overseas that shows that in a healthcare worker without other medical conditions, even just after one shot, they had about 94% of them who had protective antibodies versus 38% in patients who had solid cancers and 18% in patients with hematological cancers. So we do know that these patients are at risk of not having protection from their vaccines. So that brings me to our trial. So it's called the CIROSNet trial. It's based on a general protocol from the National Cancer Institute in the United States called CIRONet, which was designed as a serology network, is what it stands for, and was designed as a way to help people collaborate on COVID-19 research and take tests at similar time points so that results can be compared country to country and trial to trial. So our study design is taking patients with cancer in various subgroups and giving them their standard of care vaccination that they would receive anyway. And they in fact receive this through either a GP or the hospital vaccination hub. And we, at the baseline, before they have their vaccine, we take blood. We also divide them into cohorts of whether they're on chemotherapy, immunotherapy, other treatments, whether they have a hematological malignancy, whether they had treatment in the past but now in follow-up, or whether they've had previous allergies to treatment, to try and get a more nuanced understanding of what affects vaccine response. And then we take blood tests at 5 time points throughout the study over 6 months to assess vaccine response, both in terms of antibody response and in terms of T-cell immune response. We're also taking quality of life and vaccine hesitancy questionnaires at baseline and side effect questionnaires after vaccines are given at multiple time points throughout the study. So currently we are progressing well. We have been open for just over 7 weeks and have enrolled 135 patients as of the end of today who've had their baseline visit. We have an interesting mixture of patients, more females than males, probably related to the large breast cancer cohort at our hospital. Many of our patients don't speak English at home, about a quarter of them. Around a bit over half of them are of European backgrounds, but the remainder are really from all over the world. And we have every single Australian Bureau of Statistics ethnicity represented in our patient group. In terms of the reported side effects that we're seeing, these are quite similar to what is reported in trials from non-cancer patients. But the thing that's interesting is that the rates of side effects are lower than what you see in patients who have, in people who do not have cancer. So in the vaccine trials, the patients who reported fatigue was up to around 50% in young adults, a little less than that in older adults. Headaches, again, 30 to 40% less in the cancer group that we're seeing here. So far from our very early starting of our study, we know that vaccines are appearing safe in our cohort in the short follow-up we have so far. And this appears similar to what's been seen overseas. And overseas, this correlated with patients who had lower immune response to their vaccine. So it'll be interesting to see what our immune results show, and that we have a very diverse patient cohort here at Monash, which means that we can reach people from all sorts of backgrounds and study quality of life and vaccine hesitancy in these groups as well. So this is my last slide. I'm conscious of the time, but yet to come, we want to analyze neutralizing antibody results, including to variants of concern, as there's increasing concern that new variants may not be afforded as much protection from the vaccines as the pre-existing variants. We also will be assessing T-cell immune response, and we'll be assessing all of these at multiple time points, looking for decay or loss of immune protection from the vaccines. Our future hopes of where this will take us, a direct outcome of informing future vaccine policy regarding stratifying patients at need of booster doses, and telling us how long a patient might be protected from their initial vaccine series. But we also hope it might give us a better understanding in general of the immunity of cancer patients, and this might give us insights into their immune systems in general and help us with future research, for example, into cancer vaccines in the future. So it's a big project, it's just starting, but very happy to answer any questions that anybody might have. Thanks.
So any specific questions for Amy about this project or her career path, her research?
I have a question.
Sure. Can you turn your camera on if you've got one?
Sorry, I don't think my camera works.
Okay, no problem.
Yeah. What do you think the reason behind the fact that the side effects are less in cancer patients post-vaccination?
So we know that certainly the really serious side effects that you hear about from vaccination, for example, the lost the word today. Cardiac inflammation in young adults, for example, is an autoimmune type of process. So is the clotting with the AstraZeneca vaccine. And that relies on having a really robust or too robust immune response. The milder side effects that we see with vaccines, we think are related to the body's immune response to the vaccine. So like how you get a fever, a headache when you have a flu, that's really your body responding to that infection and forming an immune response. And we think it's the same mechanism that these vaccine side effects come from. So it may be that these patients are not having as robust of an immune response. The other option is just that they're people who have other illnesses and other treatments, and it's perhaps have more symptoms at baseline. So perhaps they're not noticing subtle changes in their health. Having said that, we are collecting quality of life data at the beginning and then over time to try and, I guess, weed out that as a reason, but at the moment don't have long enough follow-up for a clear answer either way.
Great question. All right, we might move on. We can have questions, or we're happy for you to email us if you want to have further discussion. So we'll go next, I think, with Amelia. Is that all right, Cam? Or thank you, Amy, very much. Beautiful presentation. Amelia, and then Cam. Is that all right? Thanks, Amelia.
All right, can you hear me?
Yes, all good.
All right, okay, so my name's Amelia McCartney, and again, I'm another medical oncologist, and I might win the award for the most circuitous route to where I am today. So I actually did 2 undergraduate degrees, a Bachelor of Science and a Bachelor of Arts, and I did an honours year for the Bachelor of Arts. And then I still didn't know what I wanted to do with my life, so I went and did a medical degree. And then I have specialised in medical oncology after sort of several years. So I'm a medical oncologist. I only see breast cancer patients, and I'm working here at Monash Health. And I'm also a PhD candidate with the School of Clinical Sciences, and I'm going to talk to you about my PhD, which is still really in its infancy. So hang on a minute, can't move on. Hang on a minute. No. Here we go. So I came back to Australia in October of last year after being abroad for 4 years in Italy. So I've just got the enviable requisite pictures here, doing a 4-year breast cancer research fellowship with this talented group of people in a town called Prato, which is about 20 minutes out of Florence. Some of you may be aware of Prato because unbeknownst to me, before I moved there, Monash actually has a campus at Prato, which was literally just down the street from where I was living. So I can speak of this place. If any of you ever get the opportunity to study abroad and go to the Prato campus with Monash, do it. It's a fantastic area. So my fellowship was not with Monash, it was with a completely independent group. And most of my PhD is based on the work that I established in Italy over the 4 years I was there. So just moving on here. So my interest is in biomarkers in breast cancer. So biomarkers in all cancers is pretty much the holy grail because we know not all cancers are the same. So we can't adopt a one-size-fits-all approach to them. And certainly even within cancer types, we know that they're not all the same. And breast cancer is probably one of the first sort of tumour types that was shown that sort of personalised medicine and biomarkers really had a standing. Now, some of you might be aware that some breast cancers express estrogen receptors, so the estrogen receptor and the progesterone receptor or endocrine receptors, and that shows a predictive and a prognostic role. So we know patients who have tumours that express those receptors usually have a better prognosis, and it also predicts for success when we give them endocrine therapies such as tamoxifen, which is a drug you might have heard of. And certainly HER2, the discovery of HER2 back before the turn of the century basically showed sort of, you know, that HER2 positive disease bestows a poorer prognosis. But then with the advent of anti-HER2 medications such as Herceptin, we saw that, you know, patients respond very well to those treatments when they overexpress or amplify the HER2 in their disease. My interest is in hormone receptor positive, HER2 negative breast cancer, which constitutes the vast majority of breast cancers that will ever be diagnosed. So about 70 to 80% of all breast cancers will be hormone receptor positive and HER2 negative. And for the purposes of my talk today, I'm talking about metastatic disease in this phenotype. So these are patients with disease that has spread throughout the body, and that is essentially a fatal diagnosis. This is something that we cannot cure, but certainly we can treat and treat quite well. So if we can identify biomarkers, this can guide our systemic therapy choices over time. And it can also identify treatment resistance. And that is a really relevant sort of question in the clinical setting, because we know that resistance is inevitable in the metastatic setting. Although patients may initially respond to treatment, over time, the disease finds ways around things and then progresses. And we need to be tailoring our treatment approaches according to this. So I'm going to show you this Kaplan Meier curve, which comes from a seminal paper which was published in 2016 in NEJM. This was a trial called Paloma 2, and it looked at the advent of using a new class of drug called a CDK4/6 inhibitor. Now, CDK4/6 inhibitors basically inhibit the CDK4/6 proteins and block the transition in the cell cycle from G1 to S phase. So they're not like a cytotoxic medication, which essentially kills off cells. They enact cell senescence. And the idea of Paloma 2 and other trials similar to this was to add a CDK4/6 inhibitor, palbociclib, to an endocrine therapy, which was considered at the time the gold standard treatment in the first line for patients with metastatic disease. So letrozole was the endocrine therapy they used. And as you can see, patients who got the doublet with the CDK4/6 inhibitor and endocrine therapy had a much better progression-free survival, so somewhat double that of the endocrine monotherapy. But I would draw your attention just to the top of the curve here. So as you can see, within 3 months, we're looking at about 10% of patients who essentially have got progressive disease. So this sort of represents a significant subgroup of these patients. So they have primary or de novo resistance to this very good drug combination. And that represents a particularly poor prognosis and unmet clinical need, because these patients in clinic, we don't really have a good strategy as how to salvage these patients. Now, CDK4/6 inhibitors plus endocrine therapy is now gold standard treatment. These papers were practice changing, and this is what we are using clinically now.
Amelia, I'm just going to jump in, sorry, because we've got about 7 minutes and then another group comes in.
Okay,
so we've got to let Cam have a go too.
Okay,
sorry.
so basically I'm going to truncate this. So I am using a refined ELISA-based assay, which basically is looking at, so thymidine kinase 1, which plays a critical role in the synthesis of DNA and cell proliferation. So what we know is high levels of TK activity in primary breast cancer tissue correlates with a poor prognosis. So high levels mean high cell turnover, bad outcomes. So I'm going to skip ahead. I'm not going to show you that. These are some Kaplan Meier curves showing patients before they get a CDK4/6 inhibitor at baseline. As you can see, if they start with low TK activity, they have a much better prognosis. So median progression-free survival of 17 months versus 7.4 months in patients with a high level before they even start treatment. This basically shows that most patients can suppress their TK levels after 15 days worth of CDK4/6 inhibition. And so these patients up here that fail to suppress their levels are probably the ones with primary resistance. And this is what we see borne out after 15 days in survival, progression-free. So patients with low levels have progression-free survival of 15 months versus 5 in patients who don't suppress.
Okay, so, Amelia, what are you doing in one sentence? Then
okay.
I'm going to Cam.
This is an investigator-initiated trial. We're going to run through Monash Health. What we're taking is blood at separate time points in first and second line therapies, and we're going to correlate TK activity with ctDNA, which is another marker that can be measured peripherally in the blood.
Perfect. Thank you so much. We're going straight to Cameron.
All right. If you stop sharing, I'll share.
Stop. There you go.
Thank you. And just got to choose the right one, that one. I hope that's coming through. So hi everyone, my name's Cam. I'm also a medical oncologist at Monash. I'm doing a little bit of a different PhD. It's based in what we call qualitative research, which all the numbers and the hard science is what Amelia and Amy are doing, and I'm doing it's kind of a bit more of a humanities type PhD, or a psychiatry PhD almost, really. A little bit about me. So I did a Bachelor of Science also in Health and Sports Science at University of New South Wales, and then went on to do medicine through UNSW as well. I then did my fellowship through the college in medical oncology. my involvement in voluntary assisted dying, I never saw myself as an advocate or a zealot for it. It just kind of happened when I was early in my career, and it was something that I didn't shy away from. So for those of you who might not know, voluntary assisted dying is a program or a scheme available in Victoria, and now WA and other states are debating, approved, implementing similar things where patients with terminal diseases can access medication to end their lives. So this became an option for patients in Victoria in 2019, just when I was starting out in practice, and it's something that I started doing. I'd always believed in patient-centered care and supporting patient choices, and this was something that some patients were going to choose, and so that was their right to, and I was willing to help them with that. So I started assessing the cases, and then that led to me noticing something, and I started being there for patients when they would take their medication. I've been there for over 50 patients now who've taken their medication. Families would consistently comment on how much it was a good death, how peaceful it was, how merciful it was. And I really felt that it might have been changing the perception of death within these families, so that they might even be less fearful of death if they knew that there was a peaceful alternative. And I wondered whether that would then lead to them changing their processing of that loss of that individual and their grief process. Around about the same time, there was also lots of opposition, and there still is lots of opposition to voluntary assisted dying. Many of them relate it to suicide, and those of us who do practice this are quite vehement that it's absolutely not suicide. And so some of the things that they quote are things like increased rates of post-traumatic stress disorder and general anxiety disorder in family members of people who commit suicide. And they also talk about things like suicide contagion, where you see it's an established phenomena where suicide begets suicide, which is a bit of a horrible situation, but that's often quoted in the opposition literature in voluntary assisted dying. And so this didn't really sit well with me because it didn't gel with what I was experiencing with at least the acute phase grief reactions that I'd experienced. And so I thought someone should research this. So I did, or I am. And coincidentally, what's happened whilst I've been kind of doing or preparing my PhD is that now there's this entity called prolonged grief disorder, and it's now in the DSM-5, and it actually has quite a clear diagnostic stem to it. So now is the opportunity to evaluate the long-term effects of being exposed to a voluntary assisted death and compare that to what we see in standard cancer deaths. So my PhD is comprised of a few things at the moment. So what I'm doing at the moment is a scoping review, which is like a systematic review, but about what's currently known about the follow-up for these people and what the effect of similar schemes internationally is on their grief and bereavement. I'm doing an audit of the case data from Victoria. I'm currently looking at a case data of around 300 patients. About 150 of them are mine. And then I'm also going to be conducting a retrospective and prospective qualitative research project into the prevalence of prolonged grief disorder, as well as PTSD and anxiety-related symptoms in close contacts of VAD patients. So that's what I'm going to be doing. There's not a lot of data out of it at the moment. There's some that's in press, and I've submitted to a conference just this week. Still recovering from that deadline, and looking forward to learning a bit more about this topic. As a side, I'm also, it's not actually a side project, but I also want to do quality of life data research in the patients themselves. I have another hypothesis about the effect of VAD application on that. So that's basically what I'm doing, and how I came to be doing it. Thought that might be of interest.
So that's great. I'm conscious we've got 1 minute left. Thanks for the quick gallop through. You know, I know sometimes you get departments presenting sort of very broadly all the different things. We've chosen to present in detail sort of 3 quite different projects. And I hope it's given you the idea that we're flexible, and lots of opportunities for interested students. So time for one question, and I'll put my email there for anyone who wants to email me, and I can pass you on to any of the speakers. We may not have our website as up to date as we should. We're busy researching. Yep, great.